This is Brian Wormers, and I'm going to be talking about intraoperative nursing today for medical surgical nursing at the University of Sioux Falls. Learning objectives are going to be talking about the surgical team, talking about anesthesia and its complications, and talking about complications of surgery. So there are many members of the surgical team. Of course, there's a surgeon and any surgical assistants, first assistants, including NPs, PAs, RNs, or scrub techs. There are anesthesia providers, including physicians, as well as CRNAs. There's holding area nurses, circulating nurses, scrub nurses. Circulating nurse does a lot of the documentation, retrieves many of the equipment. Scrub nurses is at the bedside and more of a surgical assistant. Surgical technologist works with all the tools, and they can be at the surgical assistant as well. They get things ready, lay out the table, provide the equipment. There are often specialty nurses involved, especially if it is a unique procedure or a representative from some of the manufacturers for, joints or vagal nerve stimulators or any of the implantable things that we might be using. And then operating room techs or surgical technologists can be used in a wide variety of different roles too. Minimally invasive or robotic surgery, those are getting more and more prevalent in surgeries, and the reason why is it's a smaller incision site and patients heal better with it. So very common with cholecystectomies, joint surgeries, cardiac surgeries, sometimes splenectomies, and sometimes even spinal surgeries. So with this, you've got two different laparoscopic holes. Sometimes it's even the same site, but you've got a laparoscope here that's infusing gas, and then you've got a camera on this, and so you kind of blow up the area, and then you can do procedures with your other one, such as grabbing, which is here. You can cauterize, you can cut, you can put in little bags to collect material. So you can do a lot of things through the laparoscopes, or through the scopes. Potential injury, mechanical trauma, of course, and then maybe even thermal trauma, depending on if things get hot, related to, if we are cauterizing or doing stuff like that. It is possible that people get fires within their body, but it's pretty rare. Within the environment of the operating room, we really think about patient and team safety. The layout of the operating room tends to be very similar, if possible, just to increase uniformity and standardization. Health and hygiene of surgical team is paramount. We want people healthy and effective. Of course, you're going to wear surgical attire and scrub in and scrub out. There are surgical pauses and timeouts prior to, just to make sure it's the right patient, right procedure, right person doing the procedure, correct positioning of the patient, correct equipment, correct imaging and labs are there. We really have to make sure that we're doing a good job of this. People are a source of bacteria, so we want to minimize that sometimes by limiting who's in the operating room. And then special health care standards and dress, of course, are needed with this. Watch for nosocomial infections. So depending on the surgery, you're going to see different ways that people will dress. An example of this is some of the orthopedic surgeons are dressed head to toe, wearing hoods, and really trying to protect the patient that way on those very sensitive areas. So scrubbing, gowning, and gloving, you've seen all this, you've done this, but realizing that surgical area, you're scrubbing for 3 to 5 minutes, depending on the policy and the institution. You're using wonderful soap and those conditioners, washing, and oftentimes they're even using like a hand sanitizer over the top of that. And then you're going to put your sterile gown on, gloves on, and then people will help you with your tying it in the back. Realize that prior to walking in, you're in your scrubs, you've got your booties on, or you're wearing shoes that are just for the operating room. You got your hat, your mask, your eye protection, all that stuff is on. And you got to make sure that you maintain sterility with this. Anesthesia, there's lots of different types of anesthesia. We'll go over some of the basic classes. But realize that there's general anesthesia, local anesthesia, regional anesthesia, and there's advantages and disadvantages of those. General anesthesia is what most people think about, and this causes decrease or loss of consciousness. Involves single or combination of agents, so it could be gas, could be injectables, and it depresses that CNS. And so with this, there's more side effects of this. And then, of course, if they are deep enough, which with general anesthesia they would be, that we have to manage their airway. So we can give it via inhalation, IV, or a combination of those two. Oftentimes we supplement that with hypnotics, pain medications, and maybe even some neuromuscular blocking, or paralytics. 4 stages of anesthesia for general anesthesia, so, anesthesia and sedation, relaxation, stage 2, excitement, delirium, operating anesthesia, and then, stage 4 is a little too deep. So, emergence is coming out of, it's recovering from anesthesia. So complications from general anesthesia, of course, malignant hyperthermia is a major concern, and we'll talk about that here in a little bit. But you could overdose them on the medications, could have under-recognized hypoventilation, so we're not perfusing them well enough, or we're not giving them enough oxygen and ventilating them correctly. They could have a reaction to some of the anesthetic agents, or we could have problems with intubation. So malignant hyperthermia is an acute life-threatening complication. People do die from this, unfortunately. This does tend to have familial traits. And what's going on is as you give these medications, or certain medications are more likely to cause this, but it causes the skeletal muscle to really break down. It leads into acidosis, high temperatures and dysrhythmias, and rigidity of those muscles. So as that breaks down, you get a lot of hyperkalemia, tachycardia, dysrhythmias, muscle rigidity, hypotension, tachypnea, cyanosis, and myoglobinuria, which is really hard on the kidneys. So with this, it's usually not subtle. They usually have extreme elevated temps up to like 111 degrees. Treatment is with dantrolene. And then if you're really curious about this, click on this link and follow it. And it's a great resource for it. So we kind of talked about some of the clinical manifestations. So tachycardia, cyanosis, myoglobinuria. So they're breaking down the cells, and then of course it's hard on the kidneys. Raising in your carbon dioxide level and elevated temps. Local anesthesia is a little different than general anesthesia. This is at the site. It is usually just more of a nerve block type of situation, or directed at the nerve impulses from a specific area. Patient's conscious, able to follow instructions, and often supplemented with sedatives, opioids, and hypnotics. Regional, so this is specific blocks like an epidural block, a spinal block. So you kind of do these fields, and from here on out, then that nerve plexus is numb, and they don't feel it. So I'm guessing most of you have heard of spinals or epidural anesthesia, in which we go in between the vertebrae and into that spinal canal. Complications of these, of course, anaphylactic reaction if they're allergic to the medications. Might go in the wrong space. They might have some systemic absorption of these medications. They might get overdosed, so they are numb for a longer period than expected. And then, of course, some local complications with bruising at the site. So treatment of complications, of course, good old-fashioned airway breathing, circulation, provide oxygen, notify the surgeon, of course. And then we can give barbiturates if they are having complications. And if they're having long bradycardia or something like that, we can give epi to try and increase that heart rate up. Moderate or conscious sedation. So this is kind of an in-between level. This is kind of nice because it's got less side effects on the upper airway, in that they maintain their own airway. You can follow some of the verbal commands, such as, can you move this, wiggle this, do those kind of things. And with that, the action is short, and so we can reverse it pretty quickly. Oftentimes we're given like etomidate, propofol, your PAMs, pseudiazepam, lorazepam, midazolam, pain medications, morphine, all those kind of things. So collaborative management with this, so of course, everybody in the healthcare team is working together, so we want to make sure we've got correct patient. We'll do consents, we'll do timeouts, and everybody's dressed appropriately. Everybody's going to have like a medical review, looking for any advanced directives, DNRs, complications of in the past, talking about blood and blood products, so having consent for that, seeing if there's any autologous blood transfusions that they have, reviewing labs, and then of course looking for findings. Common surgical procedures, supine, prone, those two terms, Trendelenburg, reverse Trendelenburg where their head is up, jackknife, Fowler's position. Just depends on what you're operating on and what you need to get to. So potential for injury, of course, we want to make sure that they're in kind of a neutral body position, nothing is rubbing, there's no pressure ulcerations being formed, especially for those longer surgeries if somebody's just laying there. We are constantly shifting in our seats all day, every day, moving, even on small levels. But if they are underneath general anesthesia, they don't do that, and there are increased risk for ulcerations, as well as circulation issues, respiratory issues, and even nerve impingement and conduction issues. So, of course, if we're operating on somebody, there's risk for infection. We do try our best to minimize this. So by, cleaning the area, oftentimes patients will have heavy clean showers or baths before they have surgery, trying to mitigate some of the normal flora that's on the body. Draping, cleaning, closing that skin, using different techniques, applying different dressings over the top. So really trying to protect them. Some common skin closures I'm guessing you've heard about would be sutures. So you can either do interrupted, so these are each their own. Continuous running. So the nice thing about this is it's faster, but the bad thing is if one of these breaks, then it could slip out and undo. Staples are quick and easy. The bad thing about staples, though, it does leave a bigger scar. So depending on what they're operating, what they're doing, the surgeon will kind of decide on which method they want to do. You can just do tape, like Steri-strips and stuff like that, but that's usually in addition to any internal sutures that they might have. You can do retention bridges or stays, which are just thicker sutures. So patients are at risk for hypoventilation, as we talked about, especially with general anesthesia. They need to be intubated correctly. They need to be on a ventilator, and they need to be supported. So, all right. If you have any questions on this, please contact me.